Good morning. I'd like to talk to you about PSA and just to cover a few basics that are going to be relevant to all the talk. That's a normal prostate, the size of a walnut. This is a mediumly enlarged prostate, the size of a lemon. And this is a pretty impressive prostate, the size of an apple, 100-120 mils. You'll get letters back from hospitals about laser treatment to drill a hole through that one. When prostates enlarge, they enlarge all over. When they enlarge in the central bit, that's where they put pressure on the urethra and give LUTS symptoms. When they enlarge on the outside, that's what you can feel with your examining finger, but you can only really examine around a third of the perimeter of a prostate. You can never examine that area. Symptoms that patients have are unrelated to cancer usually. It's just urethral swelling and glandular tissue at the top of the prostate. Prostate-specific antigen is made by prostate cells. The more cells you've got, the more it makes. That's why the figures go up with age. Cancer cells, a lot of them do produce PSA, but some of them don't. Their mutations have meant they've lost the ability to produce PSA. And that's one of the reasons why PSA testing doesn't correlate that well with cancer. Symptomatic patients are different. We'll talk about them later. Can I just ask all of you, quick show of hands without an examining finger, how many of you do enough PSA prostate testing, rectal examinations, to be confident of what you're finding? Food for thought. There's a study looking at this in primary care, a meta-analysis pooling together lots of studies showing that sensitivity and specificity wasn't far off 0.5. That means not very different to tossing a coin. Asymptomatic men will come to you asking for advice on wanting a PSA test. They've heard Stephen Fry talk about his cancer, a friend in the pub who had a test, was found to be positive, had treatment. He may well have survived just as well without any treatment. It's not national policy to be screening for prostate cancer, nor in America even. It's because the tests that we have and the treatment we have do not meet the standard criteria for a good screening program, and especially to do with whether benefit outweighs harm. We've talked a little bit about biochemistry, but remember that the age range alters the values, and PSA values are affected by exercise, ejaculation, prostatitis, obesity, and drugs like finasteride. It's not for the want of trying. There are lots of studies with humongous numbers, 400,000 patients followed up for 10 years, trying to look at whether there is a benefit of testing, screening or not. The problem is, a lot of the patients randomized to no test end up having a test inadvertently or because they've got anxious as the years have gone by and asked for a test. If you compare a screened population with a non-screened population, the all-cause mortality is unchanged, the prostate cancer mortality is only marginally changed, and the incidence of localized disease thankfully has gone up. The test has done something, although how useful that is debatable. For 1,000 patients screened, there'll be 170 false negatives and 115 false positives. The treatment that we do in these patients causes iatrogenic harm. These studies show significant harm. Large numbers of patients rendered impotent, significant numbers rendered incontinent, and quite a few with bowel symptoms. Not good outcomes for patients who would have lived with their prostate cancer that wasn't too invasive. So to help with this, we've got some sheets. DOH have produced something remarkably helpful that you and your nurses can give patients if they're asking about having a test. Do these sheets make a difference? Well, this Dutch study showed that without the sheets, just chatting to patients, 3/4 of them still wanted to have the test. After they received the written decision aid, only half of them wanted to have the test, and 1/5 of them decided they definitely did not want to have the test. The consequence of all that discussion on those sheets is that you could spend less time in your clinical team having blood tests, processing the results, explaining that very tortuous conversation with the borderline results, less referrals, but especially less iatrogenic harm. You can hand on your heart, in all conscience say to patients, this test will not improve your health, it won't make any difference to your survival, and it will avoid you running into harm from treatment you may not have needed. So to conclude, in asymptomatic men, please don't let your phlebotomists, healthcare assistants, whoever, tick that extra box for the PSA test unless patients know what they're letting themselves in for. Under the age of 50, unless there's a strong family history of young onset age prostate cancer, there is no value added at all. Age 50 to 70, discourage but use that decision aid. Over the age of 70, testing in asymptomatic patients will not improve their lifespan and could cause them harm. DRE has no role in asymptomatic men. How you say this to your patients and the conviction you come over with will make a difference in their behaviour. And interestingly, if they've ever had a PSA result in the past, around the age of 60 or over the age of 60 that's under 1, you can tell them with all confidence that they never need it repeating again. Symptomatic men are completely